At Ignita, we often get the question of how molecularly targeted therapies intersect with immuno-oncology therapies, which are very exciting. And so we look at it as sort of a Venn diagram where you have on one end patients that have a clear single oncogenic driver like TRK or ROS or RET, for instance. And then there's other patients that have high mutational burden. So one anecdote is a patient treated on our Star Trek 1 study named Mr. Z, who's a 46-year-old man who was on a business trip, and he was running on a treadmill when he felt suddenly short of breath. He was diagnosed with non-small cell lung cancer, had a number of different therapies, including chemotherapy, pembrolizumab, and so had immunotherapy, but had a rapid decline and unfortunately was short of breath, was bedridden, on oxygen, and was admitted to the hospice. So he had about 1 week left to live. Fortunately, was found to have an NTRK1 fusion with SQSTM1, was enrolled in the Star Trek 1 study at Mass General Hospital, and after a few weeks of oral once daily entrectinib, had a very dramatic turnaround, got up out of bed, was even able to participate in the lung cancer walk with his doctors at Mass General, and had 15 to 20 brain metastases where those went away. So he had a complete response after about a month. And as of a month ago, he was still on therapy for 14 months, still with a complete response and about 80% response in his lungs, complete response in his brain. So that's the power of precision medicine as it intersects with immuno-oncology, and it's just one anecdote where we do think that patients with these rare oncogenic drivers, you still need to shut them down with the relevant targeted agent. But we do look forward to the day when there also can be combinations of targeted agents with immunotherapies.